If you've ever been sitting in a hospital room, either as a patient or just watching a loved one get care, you probably know the ritual. A nurse walks in, they scan a barcode on your wristband, look you right in the eye, and ask you to state your name and date of birth before they hand over, like a single Tylenol.
Yeah, and they do it every single time.
Exactly. It can feel a bit repetitive, like bureaucratic overkill, especially when they just did the exact same thing 3 hours ago and clearly know who you are. But that tiny repetitive exchange is actually a surprisingly fragile safety net.
A very fragile one, yeah.
Right. And it's one with this ghostly, almost unscientific origin story that is currently at the center of a pretty heated medical safety debate. So, welcome to today's deep dive. We are unpacking what the medical world calls the rights of medication administration.
It sounds so formal, doesn't it? But it's essentially a critical checklist.
Yeah, a checklist designed to stand between routine medical care and fatal errors. We are going to explore how this checklist was born, why the original version of it is fiercely debated when things go wrong, and how this seemingly simple concept protects, or I guess sometimes fails to protect, every single one of us.
It's an incredibly important topic because the landscape of patient safety, it really forces us to look at how humans interact with complex systems. We're talking about something that is foundational to modern healthcare training.
It's basically drilled into them from day one, right?
Oh, absolutely. But when you examine the history and the underlying science of these protocols, you start to realize this mental checklist is carrying a weight it was never entirely designed to hold.
Okay, so let's get into what these rights actually are. Because any nursing student knows the classic checklist. It's the right patient, right drug, right dose, right route, and right time. The 5 rights. And reading through the source materials for this deep dive, I just assumed this list was a rigid, official, universal standard. But it turns out this golden rule is actually kind of a moving target.
Oh, it is entirely fluid. I mean, if you go to 5 different nursing schools today and ask how many rights there are, you will likely get 5 different answers.
Wait, really?
Yeah, you might hear 5, 6, 8, 9, or even 12 rights.
12?
Exactly. Over the last 30 years, educators and safety organizations have just organically bolted on new items to patch gaps that the original 5 failed to cover.
That is wild. I mean, the additions are fascinating, though. You have things like right documentation, which makes total sense in a litigious world. But then there's the right reason, meaning the nurse has to understand exactly why this specific patient is getting this specific drug.
Right. They can't just be a delivery system. They need to know the why.
And there's the right response, checking if the drug actually did its job without causing an adverse reaction. And one that really stood out to me was the patient's right to refuse. Because patients aren't just passive objects on a bed, right? They can say no, and the system has to document and respect that.
Yeah, that expansion of the list really reflects a growing recognition of how complex healthcare has become. But, the most surprising element of this whole foundational concept isn't how much it's grown, it's actually where it came from.
This is the part that blew my mind.
Right, because unlike almost every other major medical protocol, there is no founding paper.
No paper at all?
Nope. We don't have a specific randomized controlled trial we can point to and say, this study proved the 5 rights drop error rates by 80%. It just doesn't exist.
So it's basically a medical ghost story. How does an ironclad rule that dictates every single medication pass in every hospital just appear out of thin air? I mean, nursing students memorize this stuff as absolute gospel.
It's wild. I know. It really crystallized gradually in American nursing textbooks throughout the 1960s and 1970s. You have to look at the historical context, right?
Yeah.
Before World War II, the pharmaceutical arsenal was relatively small.
You had, penicillin and aspirin?
Pretty much. But after the war, the number of available drugs just exploded. Suddenly, hospital pharmacology got incredibly complex, incredibly fast. And the nursing profession, they just needed a cognitive scaffold to manage all this new complexity. So this checklist just sort of emerged as folk wisdom, a consensus among educators.
So this isn't a lab-tested formula at all. It's more like a family recipe for safety that just got passed down. Like somebody figured out how to not burn the roast, and then the next generation added a pinch of salt, and eventually everyone treats the recipe as absolute law.
That is the perfect analogy. It was a pragmatic reaction to a growing problem, not a scientifically validated intervention. And safety organizations today, like the Institute for Safe Medication Practices, they are very vocal about this. They emphasize that despite decades of universal teaching, there has never been robust empirical evidence proving that simply reciting these 5 rights measurably reduces errors.
Which is unsettling, honestly.
Yeah.
But even if it is just folk wisdom, the core ideas do make intuitive sense. I mean, stripping away the medical jargon, the guiding question behind the rights is essentially, what could go wrong right now and have I tangibly ruled it out?
Exactly. It's a defensive mindset.
And when you look at the mechanics of what happens when these rights are violated, the risks are absolutely terrifying. So let's break down that core five, starting with the right patient. Obviously, you need to ensure you aren't medicating the wrong person, but the sources are very clear that just checking a room number is completely insufficient.
Oh, room numbers are practically useless for identification. Patients are transferred, beds get swapped. Hospitals are incredibly dynamic environments. And you also have a massive issue with look-alike and sound-alike names.
Like two John Smiths on the same floor.
Exactly. Furthermore, the patient themselves cannot always be a reliable narrator of their own identity. Think about it. If someone is heavily sedated in the ICU, or they're experiencing dementia, or they're a toddler, or maybe they simply don't speak the dominant language of the hospital, you need objective confirmation.
Right.
That is why two unique identifiers, usually a full name and a date of birth, cross-referenced with a barcode scan that is the absolute minimum standard today.
Which leads directly to the right drug.
Yeah.
And this one highlighted a really crazy conflict between pharmaceutical marketing and patient safety. Because drug names aren't designed to be distinct, are they? They are engineered by marketing departments to sound memorable.
Yeah, and that marketing imperative creates massive vulnerabilities.
Yeah.
The classic example in the literature, the one everyone talks about, is insulin. You have Humalog, which is a rapid-acting insulin, and Humulin, which is an intermediate or long-acting insulin.
I mean, they sound virtually identical when spoken aloud in a busy hallway. Humalog, Humulin.
They do, and they sit in similar-looking vials in the refrigerator, but the mechanism of action is vastly different. So if a patient is prescribed the long-acting Humulin, right, to provide a steady baseline of insulin over 24 hours.
Just a slow drip, basically.
Exactly. But they accidentally receive the rapid-acting Humalog. Their blood sugar doesn't just dip slightly, it crashes immediately. They can go into severe hypoglycemic shock, leading to seizures or brain damage, simply because a single syllable was misread.
Just one syllable. That is so scary. Then we have the right dose. And the sources point out that pediatric and oncology dosing are where right dose failures become uniquely catastrophic, because we aren't talking about accidentally giving 2 Advil instead of 1.
No, not at all. The stakes are exponentially higher in pediatrics and oncology because medications are rarely standard, flat doses. You don't just hand them a pill. They're typically dosed based on a patient's weight in kilograms or their total body surface area.
So there's math involved every single time.
A lot of math. And the clinician has to calculate the exact dose while also factoring in things like renal function, which dictates how effectively the patient's kidneys can filter and clear the drug from their bloodstream.
Because if the kidneys are compromised, a normal dose just builds up to toxic levels in the blood, right?
Exactly. The clearance rate is critical. So when a clinician is doing this complex math, a simple decimal point error doesn't mean the patient gets a 10% extra dose. A misplaced decimal means a 10-fold or even a 100-fold overdose.
Oh my God. 100 times the intended dose of chemotherapy just from a misplaced dot on a chart. That is deeply unsettling.
It really is.
Which brings us to the right time. This is another one that seems straightforward but has complex mechanisms behind it. It's not just about the convenience of the nursing staff doing the rounds, is it?
Not at all. Time is intrinsically tied to pharmacokinetics, which is how the body absorbs and processes a drug over time. Let's say a patient is battling a severe systemic infection and is on IV antibiotics. Those drugs have a specific half-life.
Meaning they wear off at a very specific rate.
Right. They must be administered within a very precise window to keep the concentration of the drug in the bloodstream consistently above the threshold needed to kill the bacteria. If you are late by even a few hours, the blood concentration drops, the bacteria can multiply, and you risk breeding antibiotic resistance.
So timing is literally the medicine working or failing.
Exactly.
Okay, so the last of the core 5 is the right route. And I have to admit, when I first read the outline for this, I thought, wait, isn't right route just picking whether the patient swallowed a pill or gets an IV? How hard is that to check? But diving into the source material, I realized it is incredibly nuanced. It involves the exact physical site and the specific technique.
Oh, it is far more complicated than just oral versus intravenous. Consider an intramuscular injection, right? The medication is formulated to be absorbed slowly by muscle tissue, but if the clinician injects it into the wrong muscle group or, God forbid, accidentally hits a blood vessel instead of the muscle,
Then what happens?
the drug enters the bloodstream immediately. That is a route failure, and it alters the entire absorption profile. You get a massive spike instead of a slow release.
Wow. The sources also gave this example of feeding tubes versus central lines in an ICU, because a patient might be hooked up to a dozen different tubes, right?
Yeah, in intensive care, patients often have multiple access points. You might have a central venous catheter going directly to the heart, and then an enteral feeding tube going directly into the stomach.
And they look similar.
They're all just clear plastic tubing to the naked eye. So if a liquid medication formulated for the highly acidic environment of the stomach is accidentally connected to the port of the central venous line,
Oh, no.
yeah, you are injecting foreign, unsterile material directly into the central circulation. That kind of route failure is almost always fatal.
That is horrifying. And, knowing the theory behind the checklist is one thing, but the reality is that knowing the rules doesn't guarantee safety. We really have to pivot from the theory to the tragic, real-world cases, because the history of modern patient safety is essentially written in blood.
Unfortunately, yes. These abstract concepts only became national priorities because of devastating real-world failures.
Right, and the danger of relying on this folk wisdom checklist really snapped into focus in the 1990s. We're talking about highly trained teams at top-tier institutions failing. Let's talk about the Betsy Lehman case in 1994, because that one is just heartbreaking.
It is. Betsy Lehman was a 39-year-old health columnist for the Boston Globe, and she was undergoing treatment for breast cancer at the Dana-Farber Cancer Institute, which is one of the premier cancer centers in the world.
The irony is just agonizing. She spent her career explaining medical science to the public, and her death became this defining moment for a right dose failure.
She was receiving a chemotherapy drug called cyclophosphamide. And due to a transcription error involving that complex math we discussed earlier, she was prescribed an absolutely massive dose, roughly 4 times the intended amount.
But the mechanism of the failure wasn't just one person making a math error in a vacuum, right? What struck me about this case was the diffusion of responsibility.
Yes, exactly.
Because the order was reviewed by multiple clinicians, pharmacists, nurses, doctors. But because it was a complex experimental protocol, everyone just assumed the other person had verified the math.
That's the trap. Individual vigilance failed repeatedly. She received that massive lethal overdose over 4 consecutive days before she died. No one caught it.
It's just devastating. And it shattered the illusion that we could rely entirely on individual human vigilance. It proved that if the system allows ambiguity, even brilliant, dedicated professionals will fail to catch an error.
Absolutely. And we see that same systemic failure moving upstream in the medication supply chain with the case of Emily Jerry in 2006.
She's a little girl, right?
Yeah. Yes. She was a 2-year-old girl who had successfully come through cancer surgery, only to die from a right drug and a right dose failure. And this one happened far away from her hospital bed.
Right, this wasn't a bedside nursing error.
No. Emily's the fief bag was prepared in the hospital pharmacy by a pharmacy technician. The technician used a sodium chloride solution, essentially salt water, that was at roughly a 20% concentration. The standard, safe solution is a highly dilute 0.9%.
20% versus less than 1%. And to understand the mechanism of why that is so lethal, we have to look at osmosis. If you pump a 20% salt solution into the bloodstream, you create a massive osmotic gradient. The blood becomes so salty that water actually rushes out of the surrounding cells to try and dilute it.
It literally shrinks the cells in the brain, tearing blood vessels and causing massive neurological devastation.
It's a horrific physiological cascade.
Emily died days later. Her tragedy really underscored that the rights of medication administration don't just apply to the nurse at the bedside. The failure happened in the preparation stage, emphasizing that the entire supply chain must have built-in defenses. It actually led directly to state laws mandating the rigorous certification of pharmacy technicians.
It's good that laws changed, but the loss is just unfathomable. But perhaps the most haunting failures we read about were the vincristine deaths.
Oh, the vincristine cases are a perfect example of system design failure. Vincristine is a potent chemotherapy drug designed exclusively for intravenous use. If it is given intrathecally, meaning injected directly into the spinal fluid, the results are catastrophic.
It's invariably fatal, right?
Always.
Yeah.
When vincristine enters the spinal fluid, it rapidly destroys the central nervous system from the bottom up, causing a slow, agonizing, ascending paralysis.
Oh my God, that's horrific. But what I found staggering in the sources is the persistence of this specific error. I mean, if every single nurse and pharmacist globally is taught the right route checklist in school, how does this exact same fatal error keep repeating across different hospitals for half a century? The sources said there were over 120 cases worldwide. It defies logic.
It defies logic if you believe that a mental checklist is a robust system. But it is not. If you rely purely on human memory, eventually a clinician experiencing extreme fatigue or stress will grab the wrong syringe and make a lethal connection. The vincristine deaths forced the safety community to realize they needed forcing functions.
Forcing functions meaning a physical design change that removes human memory from the equation entirely, right?
Yes, precisely. The mandate became that vincristine could never be dispensed in a standard syringe. It had to be dispensed in a labeled mini bag.
Because you cannot physically hook a mini bag up to a spinal needle. It requires an entirely different connection port.
Exactly. You took an error that persisted through decades of mental checks, and you solved it by making it mechanically incompatible. A physical system redesign stopped the error where human vigilance had repeatedly failed.
And this brings us to the core of a very fierce internal debate within the medical community, heavily driven by the Institute for Safe Medication Practices, or ISMP. Because if you acknowledge that human vigilance is flawed, you have to rethink who actually gets blamed when a right is violated.
This is the crux of modern patient safety. The ISMP argues that the 5 rights describe the outcomes we want to achieve, the right patient getting the right drug, but they do not represent a reliable system for achieving those outcomes.
So treating them as a personal mental checklist places an unfair burden on one person.
Yes, they call it moral scapegoating. If you blame the nurse at the sharp end of the system, the person holding the needle, you are entirely ignoring the systemic failures at the blunt end.
Okay, let's define that for the listener. The blunt end being the environment that sets that nurse up to fail in the first place. We're talking about poor lighting in the pharmacy, chronically short-staffed shifts, a culture of being interrupted constantly while trying to calculate doses.
Or confusing order interfaces on the computer, or pharmaceutical companies designing look-alike packaging.
Exactly. The blunt end creates the conditions that make a sharp-end failure practically inevitable. This sounds exactly like James Reason's Swiss cheese model of accident causation.
It is the defining model, yeah.
I love this analogy. So to apply it here,
Yeah.
think of every safety protocol in a hospital as a slice of Swiss cheese. A mental checklist is one slice. The pharmacy review is another slice. The computer alert is another. They all have holes in them because nothing is perfect.
Right. Humans make mistakes, technology glitches.
But usually, the holes don't line up, so an error gets caught by the next slice of cheese. But if the holes in all the slices align perfectly, say, a short staff shift on top of confusing packaging, on top of an exhausted doctor, the error drops straight through all the holes directly to the patient.
That was a brilliant way to explain it. A serious harm event almost always requires multiple system defenses to fail simultaneously. And one of the most famous historical examples of this alignment of holes is the Libby Zion case in New York in 1984.
Right, Libby Zion. She was an 18-year-old college student who went to the hospital with a fever and agitation. And she was tragically given a painkiller called meperidine, which most people know as Demerol.
And this became a fatal right drug failure because Libby was already taking a prescription antidepressant at home, an MAOI called phenelzine.
The mechanism of this interaction is a classic pharmacology nightmare. Phenelzine, the MAOI, works by inhibiting the enzyme that cleans up neurotransmitters like serotonin in the brain. Meperidine, the painkiller, triggers the release of a massive amount of serotonin.
It's a deadly combination.
Yeah, when you combine them, the brain is flooded with serotonin and has no way to clean it up. The result is serotonin syndrome, a cascading physiological crisis causing a fatal fever and seizures.
The pharmacological interaction was the proximate cause of death, but the system failure was far deeper. It was a failure of medication reconciliation, which is the rigorous process of cross-checking a patient's home drug list against new hospital orders. And crucially, this failure was compounded by the blunt end.
The exhaustion, right?
Yes. Exhausted, overworked resident physicians making critical decisions in the middle of the night after working unimaginable hours.
That tragedy sparked a massive public outcry. It led to the Libby Zion law in New York, which finally placed strict limits on the consecutive hours resident physicians could work. The investigation recognized that the rights violation wasn't just simple carelessness. It was a symptom of a deeper systemic flaw, which was severe fatigue.
You cannot just tell a resident who has been awake for 36 hours to be more careful and expect the error rate to drop. Fatigue impairs executive function just as severely as alcohol intoxication. Recognizing that was a massive paradigm shift in medical safety.
So if human memory is inherently fallible and systemic exhaustion creates giant holes in the Swiss cheese, why hasn't modern technology completely solved this problem? I mean, everything has a barcode now, right?
Technology has certainly revolutionized the process, but it is not a silver bullet. Hospitals introduced barcode medication administration, or BCMA, and the theory is airtight. The nurse scans the patient's wristband, then scans the drug, and the software algorithm confirms the right patient, drug, dose, route, and time.
It sounds completely foolproof. The computer just takes over the mental load.
It does, but introducing technology also introduces new, unforeseen failure modes. Because humans are still involved in the physical administration, and humans under intense time pressure will always adapt. The research highlights a widespread phenomenon known as workarounds.
Oh, workarounds. What does a workaround look like in practice here?
Imagine a nurse on a night shift. The patient is finally asleep. The barcode scanner is tethered to a cart in the hallway, and the cord doesn't quite reach the bed. Scanning the wristband means waking the patient up, turning on the harsh lights, and pulling this clunky equipment into a cramped space.
Which nobody wants to do at 3 a.m.
Exactly. To save time and preserve the patient's sleep, a nurse might print an extra copy of the patient's wristband barcode and tape it to a clipboard, or even to the wall outside the room so they can scan it quickly without entering.
Wait, really? That scanning workaround sounds exactly like buckling a car's seatbelt behind your back just to stop the warning chime because you're in a massive hurry. The technology is actively trying to save you, but human time pressure defeats the safeguard entirely.
That is a perfect analogy. The tool becomes a hurdle rather than a safeguard. And compounded with workarounds is the issue of alert fatigue.
Alert fatigue.
Yeah, modern electronic health records are incredibly sensitive. They pop up with a warning for every minor, potentially irrelevant drug interaction. If a clinician sees 50 yellow warning boxes a shift that turn out to be harmless, they develop muscle memory to blindly click ignore on every pop-up.
Just clicking through terms and conditions.
Exactly. And eventually, they click right past a critical, life-saving red alert.
Which explains why for the most dangerous drugs, the high-alert medications like insulin, opioids, or chemo, they don't just rely on one nurse and a computer scanner anymore. They require extra independent double checks, forcing a second nurse to separately calculate and verify the dose.
Redundancy is the only proven defense. And all of these realizations from forcing functions to alert fatigue have really culminated in a modern healthcare management philosophy called just culture.
How does just culture change the environment on the hospital floor?
It attempts to resolve the tension between individual accountability and system design. Under a just culture framework, individuals are held strictly accountable if they engage in genuinely reckless behavior like charting a medication they never actually gave or coming to work impaired.
Sure, that makes sense.
But crucially, it mandates treating honest, foreseeable human error as a system design flaw to be fixed. If a well-meaning nurse makes a mistake because 2 drug vials look identical and the lighting is poor, you don't fire the nurse.
You change the lighting.
You change the lighting and mandate different packaging. It fosters an environment where clinicians feel safe reporting near misses, allowing the system to learn and adapt rather than burying mistakes out of fear of termination.
That is such a vital shift, because when you look at this entire landscape, from the ghostly origins of the 5 rights in the 1960s to the complexities of alert fatigue and workarounds, it really changes how you experience care as a patient. The 5 rights are a floor, not a ceiling.
Definitely a floor.
The Institute of Medicine's landmark 1999 report estimated that tens of thousands of Americans die every year from preventable medical errors, with medication-related errors making up a massive portion of that tragedy. And that's not an abstract number.
No, those numbers represent a profound loss of life that stems from incredibly complex systemic interactions, not just simple negligence.
They're real people, like Betsy Lehman and Emily Jerry. So, to our listener, the next time you are in a hospital bed and a clinician pauses, looks at your wristband, and asks for your name and birth date before handing you a medication, you realize you aren't just answering a repetitive question, You're actively participating in a decades-old system of redundant defenses.
You are acting as the final critical patch over a hole in the Swiss cheese. The patient is truly the final check in the system.
But there's a final kind of provocative thought I want to leave you with to mull over on your own. We have seen that human vigilance inevitably fails, even among world-class experts. And we have seen that digital barcode systems are regularly defeated by exhausted clinicians who are forced to create workarounds just to survive the pus of their shift. So maybe the ultimate future of patient safety shouldn't be about adding more checks to a mental list or installing louder alarms on a computer screen. Maybe the future requires entirely redesigning the physical tools of healthcare, just like they did with the vincristine syringe, so that making a fatal mistake doesn't just trigger a warning chime, it becomes mechanically impossible. Moving from a culture of be more careful to a system where it cannot be done wrong. Something to think about the next time you hear that familiar question. Can you confirm your name and date of birth for me? Until next time, keep diving deep.